Very, very happy to hear. And but before we get into our speaker, do we have anyone with us tonight that is celebrating a birthday, anniversary, any milestones that they'd like to share with us? If you do, you can either open your mic and let us know. If you type something in the chat, we'll read it out to you. We'll celebrate you. So feel free to let us know. No one's celebrating, boy. We haven't had a birthday celebration for a while. Y'all scared we can make you bring us cake? You can tell us.
Rochelle, I'm not celebrating a birthday, but the 16th of this month will make my 10-year anniversary married to my wife.
Awesome. Happy anniversary.
Thank you.
To you and her. Probably more especially to her.
Very much. Very much, yes.
Congratulations and happy birthday to both of you.
Happy anniversary.
How many years?
10.
Wow, awesome.
Fresh in the game.
Yeah. All righty. Anyone else celebrating anything? Okay, well, if you think of something throughout the course of the evening, put it in the chat or let us know at the end of the presentation. Up next, we're going to have Erin with some announcements telling us what's going on in and around the Cancer Society. Erin, are you there?
I am. Give me one minute. So talk for 2 minutes. Give me a second.
No worries.
All right. The Cancer Society. Hold on. Lord, we haven't had this meeting for so long. I feel like
recording in progress.
Exactly. I forgot to do that. All right. The Cancer Society. Well, we have a campaign going on called 50 for 50. I'm trying to bring it up so everyone can see what's going on. Can you see my screen?
Yes, we can.
Okay, let me see if I can work this where it is showing all of that I need to show and not anything else. What are you all saying? Me clicking everything off?
No, we have the flyer for this evening and some other things on the side.
All right. So we have Dr. Major speaking on stomach cancer. We've had a few persons diagnosed, so this is one of the cancers now that a lot of persons are experiencing. But this is what we're talking about. We have the 50 for 50 campaign going on and celebrating the Cancer Society 50 years of hope, care, and community. And we're looking for persons, organization to donate $50 or more in multiples of 50. We're even looking for organizations to give us that big amount, which is like $50,000 for 50 years. And that will help us with our expansion project, which will, construction will be starting. Groundbreaking will be in May. So thereafter, construction will be starting. And, we're gonna add 10 more additional rooms, not just for Family Island persons, but also for Nassau-based residents, like single persons live alone, have to take treatment, have nobody to be there with them right after treatment. And our long-term goal to have affordable hospice care, which is so needed here in Nassau. So if you guys could just take a picture of this flyer and the QR code, it will take you directly to make a donation, and we will be so happy to have it. And this is going to be a campaign that is going to be for the entire year into early next year. So, you can do your bank to bank transfer, or you can set up reoccurring payments where you do $50 a month. And this definitely will help us in our expansion. We're coming soon. We have some new apparels coming out for this year, the 50th anniversary. So this is a glimpse of what's coming soon. And the colors, the four colors are depicts the four major cancer. We have the lavender, which is all cancer. We have the pink that everybody knows, breast cancer. We have the teal, that is cervical cancer. And then the blue, that is representing colon cancer, which is the fourth leading cancer being diagnosed in the Bahamas. So these are the polo shirts. We also have tees, and we have them in different color and different style. This is the one with the white, and the leaves are in the different colors. Hopefully, as the year goes and we have great sales, we probably will add the other different color of cancer, so persons could recognize their cancer and celebrate. We also will be having dresses. This is just a sneak peek of what we are looking for in dresses. Again, it will be in the four major color: lavender, pink, teal, and blue. And we also, men, y'all are not left out. We have your button-up shirts for you too. So these will be coming out shortly. So stay posted to our social media page. And if you'd like to subscribe to our newsletter, just go to our website and www.cancersocietybahamas.org and subscribe to our newsletter, and you will keep in the news of when the shirts and everything are here. And this is the blue one for the men. So this is what is happening, and we would like for everyone, to assist us in this endeavor, because 50 is a milestone, and the Cancer Society has been here helping those with support group, financial assistance, accommodation, and we'd like for the general public to continue to patronize us as we move into another 50 years. So if you'd like to have that QR code again, I could put it back up for you guys. You can go to our website or our social media pages, which is our Facebook or Instagram, and you will see this flyer every day, and you can just click on the QR code and make your donation. Thank you so much. Any questions? I see somebody had a hand raised. You want to open your mic? I don't see them anymore, so. But if you do, you can put it in the chat and I will be there to answer any questions. Thank you so much, and I will take it back to Ms. Rochelle.
For those of you who, I think Aaron didn't mention, but we also have our ball coming up next month at the Atlantis Paradise Island. And Aaron, help me remember the theme, please. Aaron? She's gone. Okay, I think it's I'm not feeling well, so forgive me. But the theme is celebrating the 50 years of hope, and under the theme of Egyptian nights. Promises to be quite an exciting and interesting night. So it will be held the last Saturday in May, which is May 30th. So if you go to our website, you should see the details to save the date for that. So we look forward to seeing many of you there with us that evening as well. So we're going to get started now. We're going to bring on our speaker, who is Dr. Don Major. And before I read his bio, I will just let you all know that Dr. Major is one of our new entrants on the board. He's recently joined the board of the Cancer Society of the Bahamas, and we're so grateful to him for doing that. And this is his initiation, I guess you could say. So he joined the board last month, and immediately we put him to work, and he didn't mind at all. So thank you so much, Dr. Major. Go on with the show. Dr. Major is a prominent figure in the medical field, known for his expertise in cancer surgery and oncology. He is currently a consultant surgical oncologist and hepatobiliary surgeon at Princess Margaret Hospital in Nassau, Bahamas. And if I didn't get that word right, he'll correct me when he comes on. Dr. Don Major was the first Bahamian to complete his surgical residency at the University of the West Indies, or UWI, Bahamas, and has extensive experience in surgical oncology. And here's that word again, hepatobiliary surgery. Dr. Major's professional background includes a fellowship at the Tom Baker Cancer Center in Calgary, Alberta, and he is recognized for his contributions to the field of cancer surgery. His work has been recognized in academic publications, reflecting his significant impact on the medical community. Dr. Major's dedication to his profession and his commitment to providing quality care to patients is evident in his work at the Cancer Surgery Center in the Bahamas. His expertise and contributions to the medical field continue to be a valuable resource for patients seeking advanced cancer treatment. Dr. Major is married, as he told us, for 10 years with 3 children. So welcome, Dr. Major. And can you let me know if I was saying that word correctly?
It was close enough. It's it's hepatobiliary. Yeah. So basically
Okay.
liver and gallbladder surgery, pancreas. Yeah, yeah. Well, thank you for that warm introduction, Rochelle. And I would like to thank the Cancer Society for allowing me this opportunity to come here tonight and present on a topic, gastric cancer. And I'm pretty excited to be here. The fact that I'm a new board member and the fact that I'm a new board member in the 50th year. I look forward to another great 50 years for the Cancer Society. So I'm just going to share my screen now. Are you able to see it?
Yes, gastric cancer awareness.
Okay. All right. So tonight we're going to go over gastric cancer and some of the things that we should all be aware of when it comes to this cancer. Presently, I don't have anything to disclose, so we're just going to jump right into it. This is a brief outline of what we're going to go through. So if we look a little bit at the anatomy of the stomach, as we can see here, is in the upper abdomen. Usually on the left side is this pink tubular looking structure. And that is where basically once we eat food, it goes into the stomach and it gets churned up into smaller particles. And it gets mixed with acid and then sent along to the small intestine. When we look at stomach cancer, basically this is cancer that arises from the lining of the stomach. It's pretty much the 5th most common cancer that's diagnosed within the world. And it's the 5th leading cause of cancer-related death globally. However, the highest incidence usually occurs in Northeast Asia, cities such as Japan and China and Korea. When we look on this side of the world, in the Western world, we think that the incidence of gastric cancer is decreasing. And it's only about the 15th most common diagnosed cancer and the 15th most common leading cause of cancer-related death. If we look at figures here that come from our cancer registry, and we look all the way down to the bottom, that is stomach cancer. This registry started in about 2009, and this is up to 2022. And as you can see, the number of stomach cancers range anywhere from 9 a year to as high as about 19 per year. So it's not something that we see a whole lot of. And I could be honest, seeing patients with gastric cancer I tend to only see maybe at maximum 3 or 4 a year. And the majority of these I'm not able to operate on because you'll find out now as we go on. Some of the risk factors for actually developing gastric cancer basically are family history. So if you have a strong family history, other family members may have gastric cancer. So it's about 1 to 3% of them are hereditary. H. pylori infection, as well as diet. When we look at risk factors, we talk about things such as modifiable risk factors versus non modifiable risk factors. And as it says, non modifiable risk factors are risk factors that you can't do anything about. So you can't do nothing about your genetics, you can't do anything about your family history, your age. As we age, gastric cancer kind of comes up on us. Individuals over the age of 50 are more likely to develop it. It's more common in men. Men have a 2 to 3 times increased risk of developing gastric cancer. It tends to occur more commonly in Black individuals, individuals with blood group A, diabetes, gastritis. If you've had previous resection of your stomach for whatever reason, you may have had an ulcer and you had to have a portion of your stomach resected or removed, this can increase your chance of developing gastric cancer. Now, when we look at the modifiable ones, so things that we can actually do something about, the number one risk factor is Helicobacter pylori, which is a bacterial infection. I'm going to talk a bit more about that after this slide. Things such as smoking, alcohol intake, increased coffee intake, obesity with sedentary lifestyle, increased red meat intake, occupational exposures. All of these things are things that we can do things about, but they can actually increase your risk of developing gastric cancer. So H. pylori or Helicobacter pylori, this basically is a stomach infection, or it's a germ called H. pylori that is found within the gastric lining. More than half of the people in the world will have some H. pylori infection in their lifetime. It's a germ that spreads via direct contact with person's bodily fluids, things such as vomitus, saliva, stool. It usually happens in individuals who have poor hand hygiene. So you don't like to wash your hands and you go ahead and you eat your meals after having after touching something that's been contaminated, then you increase your chance of ingesting this bacteria. And they can actually spread through tainted food and tainted water. Some of the symptoms that are associated with H. pylori are dyspepsia or stomach pain, bloating, gas. Sometimes you can get some burning behind the sternum after you had a certain meal or a spicy meal. But most people who actually have H. pylori don't even know they have it. They tend not to have any symptoms. Some of the other risk factors for developing H. pylori, so individuals who live like in a crowded environment, so things such as jails, etc. If you lack reliable supply to clean water, if you're living in developing countries, and if you're sharing food or utensils with individuals who may have an H. pylori infection, you can actually spread that on to yourself. How we diagnose that? It's a common breath test that can be done in office, which is the gold standard for diagnosing H. pylori, where you actually drink a special solution and then you breathe into this bag to detect the carbon dioxide released from the bacteria. There's also a stool antigen test, or sometimes an endoscopy, which is when we pass the camera down the mouth and have a look in the stomach. We can see some inflammation in the stomach that may think us that, hey, something may be going on here. And we take a little biopsy and we send that off, and it can tell us whether or not H. pylori is present or not. And who should we actually test for this bacteria? Knowing that this is the number one cause for gastric cancer, we tend to test patients who actually have symptoms. So the similar symptoms that we talked about, heartburn, bloating, a gassy feeling. If you have a family history of stomach cancer, you should get tested for H. pylori. If you've been on long-term NSAIDs or things such as ibuprofen or anti-inflammatories, these can increase your risk of developing ulcers and H. pylori infections. So if somebody has an iron deficiency anemia, so the blood count is low and they can't necessarily determine why, then this person should be tested for H. pylori. And individuals who have been or who are known to have H. pylori, they've been treated and it's thought to have been eradicated, you usually want to do a confirmatory test that it's all gone afterwards. Treatment for H. pylori is pretty standard. Once it's been diagnosed, all you need is a 2-week course of antibiotics with a proton pump inhibitor, which is something like Nexium or an antacid to kind of reduce the acid in the stomach. And once that's over about 2 weeks, then you're generally cleared from that infection. Now, moving back to stomach cancer, when we look at the actual pathology related to it, the most common type of stomach cancer is adenocarcinoma. So this arises from the glands within the stomach and accounts for about 95% of gastric cancers. And when we look at how we classify these gastric cancers, it's generally either based on location. So if it's high up in the stomach or the cardia, it's considered proximal. If it's low down in the stomach, it's considered distal. And then we also classify it based off of pathological examination or review via the histological subtype, whether it's diffuse, meaning it involves the entire stomach, or if it's intestinal. And intestinal tends to involve a certain portion of the stomach, whether that's proximal or distal. When we look at the morphology, how it looks, the intestinal type, these type tend to be a bit better because they tend to be bulky tumors and they tend to be localized to one area. They form like an exophytic mass. When we look at the diffuse type, however, these type tends to be a bit more aggressive and not as favorable because they are very infiltrative along their growth. So you may be looking at, a portion of the stomach that looks normal, and it could be an infiltrative cancer or a diffuse type because it affects the entire lining of the stomach. I know we talk about stomach cancer, but then you also have to think about things such as screening because stomach cancer is pretty bad. But generally, for stomach cancer, we do not screen. Even though we know that stomach cancer carries a very poor prognosis and it tends to be diagnosed at an advanced stage, it's just because we don't see that many of them that this is something that we would recommend screening for. It's not like breast cancer or colon cancer where the numbers are super high. So we know that a lot of individuals may get this, so we screen for it. Like I said, when I showed you the data for the Bahamas, at most in a year, you probably get 15 with a population of over 400,000. Yeah, that's a lot of screening to do just to capture that small amount of people. But generally, in places where the incidence is pretty high, like in Japan and South Korea, they actually have population-wide screening. And this is where they actually detect these cancers at a very, very early stage, and they tend to have improved outcomes once detected early. Some of the symptoms of gastric cancer can resemble those symptoms of H. pylori infection. So things such as dyspepsia or heartburn, so you get that burning sensation. Dysphagia, meaning that sometimes when you eat, you feel like the food just getting stuck or it's difficult to swallow. Sometimes you feel nauseous or you may even have some vomiting. And then you have these constitutional symptoms, things such as weight loss, unintentional. So you haven't changed anything, you haven't changed your diet, you haven't started exercising or anything, but you're dropping weight and you can't explain why. Your pant size or your belt size is getting smaller. Anorexia, so you're not hungry. Early satiety, so normally you're somebody that can eat an entire plate of food in one sitting, but you find yourself only eating maybe a half or a quarter of the food, and you're feeling full. Anemia, and usually anemia presents like things like feeling tired all the time, low energy, and then finally gastrointestinal bleeding. So you may have some vomiting of some blood, or when you pass stool, it looks black like tar. So all these are signs that something's not right with your stomach and you need to get it evaluated. And evaluation comes with baseline laboratory investigations, things such as a complete blood count, looking for any evidence of anemia, basic chemistries, and the mainstay of evaluation is the upper endoscopy. Generally, after you've had the upper endoscopy, and this is where, as you can see in the photo here, they pass a camera down the mouth and into the stomach and just have a surveillance of the stomach and the proximal small bowel. If there's anything found, then you'll generally go on to get a CT of the chest, abdomen, pelvis, and sometimes you may end up getting a PET CT if there's a gastric cancer that's identified and diagnosed. this is an endoscopy finding, or these are multiple endoscopy findings of what it looks like on the inside of your stomach. There's a gastric cancer. You can see the one all the way to the left. This mucosa, or the lining of the stomach, is pretty heaped up, and there's some necrotic tissue at the base. And the one in the middle, they're like this crater with this hypergranulation tissue, and the one to the far right, there's like this umbilicated portion where the mucosa seems to be pulled in. All these are signs of gastric cancer when you actually put the camera in and they warrant biopsies to send to the lab. When you eventually do your CT scan, if there's a suspected cancer, you look at the location of the cancer on the scan and you see these arrows pointing here. The bigger arrow is actually pointing to the stomach, and it's pretty thick walled, and that's usually representation of a cancer. And then the smaller two arrows are pointing to what we know as the omentum. The omentum is the fat that lines that drapes from the stomach and lines over the intestine. And sometimes cancer spreads from the stomach to the omentum and causes this nodular appearance of the omentum. It's called omental caking. So if we've done a biopsy, we've seen something in the stomach, we've gotten our CT scans, gotten a biopsy, then the next thing is to stage this patient. So staging of gastric cancer basically kind of gives us an idea of how far this tumor has gone, whether or not it's an early tumor, whether or not it's localized, or whether or not it's spread to other parts of the body. And the CT scan and the PET CT are pretty good diagnostic tools to help us to determine the staging. So again, localized cancers, so very early, so T1 or TIS tumors, local regional cancers, so T1B and greater. So these are bigger tumors, and if they have any nodal involvement, and metastatic tumors are those that have tumors elsewhere. So it has the primary in the stomach, and then when you look, you see something in the liver, or you may see something in the lung, or even you may see something in the omentum. So we treat these individuals with gastric cancer based off of this stage. So we subdivide them whether they're localized. Like here, if they're localized, so they're early, which is something that we rarely see here on this side of the world. But if you're lucky and you got an early diagnosis of a gastric cancer, there's an option of an endoscopic resection, meaning that they can use that same gastroscope or endoscope, go in, find where the tumor is. And these are generally very tiny, small tumors. Find where the tumor is, and then endoscopically take it out with a negative margin. And generally, that's all that's needed for that person. But again, bear in mind that these very small tumors, even though they're T1A, so they're only in the mucosal lining of the stomach, up to 5% of them could already have spread to the lymph nodes. So that's something that you have to be aware of when you recommend this treatment option for those patients. So the majority of patients would get some form of surgery. And surgery is usually redeemed for the bigger tumors and those who are not necessarily metastatic. So if you are deciding to go ahead and perform a surgery or have a surgery done on you for gastric cancer, generally you'll need to have a laparoscopy before they go ahead and do the surgery. And the reason for that is sometimes when you look at the CT scan, when you look at the patient, you may not be able to pick up those small areas of metastasis. And when we put the camera in, so we just go in, put you to sleep, put the camera in through the belly button, have a look around, and we just make sure that there's no signs of spread that was not picked up by the CT scan or the PET scan. And we also do what we call peritoneal washings. So we instill fluid on the inside, kind of wash over the stomach, and then we take that out and send that to the lab, because if there's cancerous cells in that, even though you may not see them, these patients are considered metastatic because they behave metastatic. Even though when you're looking at it, everything all looks fine, but those cancerous cells within that fluid that you washed the belly with puts them up to M1 disease. And looking at the scan, looking at the patient, and it looks like it's localized disease, up to a third of these patients, so 31% of these patients actually become metastatic after you've done your laparoscopy. So looking at it on the laparoscope, this is what we tend to see sometimes when we go in there thinking that, hey, this is gastric cancer, they should be okay, it looks resectable, but then you stick the camera in and then you see all these white spots. And these white spots are all signs of peritoneal spread. So basically, the cancer has now moved from the stomach and spread along the lining of the anterior abdominal wall. And you tend to biopsy one of these, send it to the lab, and it confirms that it is cancer. And generally, in these cases, we don't do any form of surgical resection. Most commonly, we'll send them for chemotherapy for palliation. Some of the limitations, however, you cannot necessarily identify metastasis within the liver. You can see it on the surface, but those that are deep to the liver or deep within the liver parenchyma, you can't necessarily identify them. And then those with big or perigastric lymph nodes that are positive, you necessarily can't identify that either. But again, like I said, if you have a positive cytology, so that fluid you send off, it shows it has cancerous cells in it, then these patients tend to have a poor prognosis, even if you don't see anything visible. And generally, surgery is not recommended for those patients. So how do we know some patients with gastric cancer are going to do poorly? If they have advanced disease, and up to 50% of individuals, when they do present, they have advanced disease, meaning they have big, bulky tumors, big lymph nodes, or even evidence of distant spread. If they have poor performance status, meaning that they have comorbidities that are not controlled, so they're poorly controlled diabetic, poorly controlled hypertension, they've had a previous stroke or previous MI, limiting their mobility, these individuals, they tend not to do well. Obviously, if there's a presence of metastasis, and then if you have a large number of lymph nodes, these individuals also tend to have a poorer outcome. So surgery is the primary treatment for localized gastric cancer. And what we want to do is we want to take that tumor out, and we want to take it out with at least a 5-centimeter rim of normal stomach. So we end up taking quite a bit of stomach when it comes to gastric cancer. The two main surgical options that we choose would be what we call a subtotal gastrectomy, which is where we take out about 75% of the stomach, or the other option is a total gastrectomy, which we take out the entire stomach. And we also take out the surrounding lymph nodes as well to also test them to make sure that there's no cancerous spread to these. So looking at this, again, picture of the stomach, the subtotal gastrectomy would be where tumors are down at the lower end by the pylorus. And then for the total gastrectomy, it would be more proximal tumors that are up by the fundus or cardia. You end up having to take the entire stomach. So if it's not, or if it's considered unresectable, meaning that, hey, we can't get this thing out. Again, if they have peritoneal involvement, so you see those white deposits, if they have distant metastases, and finally, if this tumor is invading into big arteries in the back, so basically the celiac trunk, which is the main artery that supplies blood to the stomach and to the liver. If the tumor or lymph nodes are wrapped around these vessels, then these individuals, again, we cannot necessarily take these out safely and preserve the patient's life. When it comes to the surgery, it can either be done laparoscopic, open, or robotic. We here in the Bahamas, we don't have the robot just yet. So commonly we'll either do it laparoscopic or open. And there are much benefits for laparoscopy when it comes to this type of tumor. Obviously, there's less blood loss. You have reduced postoperative pain. So with the laparotomy, you end up having a big up and down cut, usually from just below the breastbone here down to the belly button. Sometimes you go a little bit lower. And you can imagine having to heal up after that. Usually you spend about 7 to 10 days in hospital recovering from the wound itself. But with the laparoscopy, you have about 5 or 6 very tiny incisions about the abdomen. We blow up the belly and we can get it out safely that way. You would still have to get probably like a 5-centimeter incision just to get the stomach out, but it wouldn't be nowhere as near as the full-on laparotomy. And these patients tend to have an accelerated recovery. So if you were able to get it out safely laparoscopic, you may only spend about 3 days in hospital as compared to the 7 to 10 having to do it for full-on laparotomy. And they tend to have an early return of their bowel function and, again, a reduced hospital stay. These patients who undergo laparoscopy, they tend to be home much quicker and recovering much quicker. perioperative chemotherapy is quite important with respect to gastric cancer management. So we don't necessarily go straight forward to surgery in the majority of our patients because there has been a landmark paper called the MAGIC trial, which basically tells us that if we give chemotherapy first, followed by surgery, and then chemotherapy after, these individuals tend to have a better overall survival, as well as it also improves their progression-free survival. So this is now considered the standard of care for locally advanced gastric cancers. So if you're diagnosed with stomach cancer and it's not super early and it's not metastatic, 9 times out of 10, you're going to get some form of chemotherapy first, and this is going to be followed by surgery. And we call it like a sandwich technique. And then afterwards, you'll get your remainder of your chemotherapy. And again, this is for patients with larger tumors. If they have obvious nodal involvement, or if this thing may be invading some structures deep, and you want to kind of get it to shrink down, and you want to destroy any evidence of any micrometastases, so little small things that may be breaking off and spreading elsewhere. You want to get those controlled. We end up giving the chemotherapy first. Now, the MAGIC protocol was an older chemotherapy or sandwich chemotherapy model. We now use the FLOT, which basically consists of 5-FU, leucovorin, oxaliplatin, and docetaxel. They are all chemotherapeutic agents, and we tend to give 4 cycles of the FLOT prior to surgery, and then we reassess just to make sure that there's no progression of disease. And usually about 6 to 8 weeks after the FLOT is completed, that first session, then we go ahead and we take you to surgery, and we either do the subtotal if it's a distal tumor, so we take about a 75% of your stomach, but if it's a more proximal tumor, you may end up getting a full-on total gastrectomy. And once the stomach comes out in the total, we tend to anastomose or hook the distal esophagus up to a piece of small bowel. So you don't necessarily need the stomach because, again, the stomach's only real role is kind of storage of food and kind of churning the food. But definitely if you have your stomach removed, your entire stomach removed, then the way in which you eat food may have to alter a bit, right? So additional reason why we've chosen to use the FLOT over the ECF or the MAGIC protocol, because it's less adverse effects, so less neutropenia, less leukopenia, less nausea, infection. It's actually tolerated much better than the MAGIC protocol, right? And when we look at it, we look at basically the outcomes, and it's showing that the overall survival with the FLOT has increased to about 50 months compared to 35 months with the ECF. So patients are living longer with the FLOT when compared to the ECF. And again, like I said, FLOT is just that chemotherapy given first, surgery after, then chemotherapy at the end. Now, we find out that sometimes individuals are not well enough to tolerate that chemotherapy at the end because this is a pretty big operation. Let's say to take somebody's entire stomach out, you're probably looking at about 5 hours on table. And there are complications that can occur after you've had your stomach removed. And the main thing you kind of worry about is bleeding and where we join you back up. If that breaks down, then that could be a pretty detrimental issue. And you may end up spending weeks to months in hospital having that taken care of. But again, the complication rate for these types of cancers tends to be within the 5 to 10% range. So it's not super high, especially if it's in an elective setting. Sometimes your hands are forced for these gastric cancers that are resectable because let's say a patient comes in bleeding profusely from the stomach and they can't get it controlled by endoscopic means, or if it's causing a blockage. So it's down there by the pylorus and it's blocking off the outlet of the stomach and patients are persistently vomiting. These individuals, you may have to go in and actually do a surgical resection prior to chemotherapy. It's not ideal, but again, if the patient can't eat, or if the patient's bleeding profusely, or even if the tumor perforates, so it creates a hole in the stomach, and now you have stomach content leaking outside and into the abdomen, these patients can get pretty sick. and they can become septic and eventually die. So these cases now, where you have these complications, you actually want to go in and do surgery in an emergency setting. And then when you're doing emergency surgery, the risk of complications tend to increase. But in the elective setting, gold standard right now is considered flawed. It's very rare that we give radiation therapy, right? Because generally, once we go in there for this tumor, so whenever we decide to operate, we tend to get it all out. Because if we know we're going to go in there and we're not going to get it all out, so it's going to be something what we call an R1 resection. So we're leaving behind microscopic cancer, on R2 resection, where we're leaving behind gross tumor. That's generally not a good thing for the patient because the recurrence rate is super high in those cases. So once we decide to go in, especially in the elective setting, we're generally going in to get an R0 resection, meaning that we're going to go ahead and get that entire tumor out. But for those individuals where we don't get it out, then these individuals will end up getting radiation therapy to the bed where the tumor was at some point. And again, these for really aggressive cancers, individuals who tend to be much younger. So if you have maybe a 30-year-old with gastric cancer, a 30-plus-year-old, you may want to hit that person with everything on the kitchen sink because these tumors tend to be so aggressive. And if you do not as good a surgery, because generally you want to take out between 16 to 30 lymph nodes, and if you have only gotten about 5 to 10, then you know this was an adequate resection, so these individuals need to get some mop-up radiation therapy. When we actually remove the specimen, we send it off to the pathologist. The pathologist is now going to determine, the exact pathological stage, how deep this tumor has invaded into the stomach, where exactly in the stomach is this tumor, whether it's proximal or distal. We're going to look at the margins to make sure you've gotten it all. And you're also going to look at the lymph node status. Again, an adequate surgery means that you've gotten more than 16 lymph nodal harvests when you actually remove the stomach. After surgery, and you've completed your final flot or your final end of your chemotherapy, and we've now deemed you cancer-free, basically there's surveillance. So in general, surveillance is where we kind of follow you for a period of about 5 years, just looking for anything that may come back. And we want to try and catch that. If it's going to come back, we want to catch it early. And we want to be able to do something about it as opposed to just sending you on your way and then you come back 4 or 5 years later and the thing is already advanced and there's really not much we can do. So general surveillance for all patients, we want to kind of see them every 3 to 6 months after surgery and after they've completed chemo for the first 2 years. And you do a history and physical examination. And then once they've passed that first 2 years and everything is pretty much okay, then you want to see them every 6 to 12 months for the next 3 to 5 years. And when you see them, you're going to do a baseline chemistry and CBC. And for individuals with early stage cancer that was endoscopically resected, they're going to get actual endoscopies every 6 months because, again, you want to make sure that this thing isn't coming back. And then generally after the third year, then they'll get endoscopies every year. And then basically, it only should be performed, the endoscopy, for patients who it's actually clinically indicated. So again, this is for individuals who are beyond the T1 stage or beyond that early stage. So if they're having symptoms again, if they're having dyspepsia, or they're having some kind of feeling of food being stuck on their chest, then you may want to put a camera down and have a look and try and see what's happening because recurrence is real and it's something that can happen. Right. So for patients with more advanced staging, so stage 2, stage 3 disease, so stage 2 meaning that it's a bit bigger cancer with no lymph node involvement. Stage 3, a bigger cancer with a spread to the lymph nodes. These individuals now, every 6 months, for the first 2 years, they're going to get CT scans. So on top of you seeing them every 3 to 6 months with your physical exam and your blood investigations, you're actually going to scan these individuals. And then after the first 2 years, they're going to get CT scans annually for up to 5 years. Because again, you really want to determine if anything's going to come back and you want to catch that early. Because we are very aggressive with this tumor because the mortality rate with this is pretty high. And again, majority of these patients, when they do present, they tend to present in an advanced state. So most gastric cancer recurrences, they tend to recur within the first 2 years, about 70 to 80% of them. But if they are going to recur, the majority of them recur within that first 5 years. So this is why we kind of use the 5 year mark, because we know that if it's coming back, 90% of people will come back within that 5 year time period. Usually after that, usually less than 10%. If you make it beyond the 5 year period with no recurrence, usually less than 10% of those people will actually come back in. So some of the take home points tonight from my gastric cancer talk. Gastric cancer screening is not performed in the Western world. Again, reason being because it's not a high incidence. Even though it is pretty bad when you get it, it's not something that a lot of people do get. And because there's no screening, it's most commonly diagnosed in an advanced stage, right? So this is where it's very important that you have your family physician or your regular doctor or your GP that you see routinely. Right? So you should see them every 6 months to a year. And if you do experience any symptoms, things such as bloating, Bahamians, we always say we got gas, these kind of things, don't just brush them off saying I could go drink some tea and I could be okay, right? So if these things have been going on for a while, have them looked at, right? Because something simple as a breath test, you can determine if you have H. pylori and you get some antibiotics and you treat that and you can clear that all up, clear up the number one risk factor easily, right? So that's very important. Make sure you have your regular clinic visits and just chat with your doctor and let them know how you're feeling and if there's anything that you're worried about, that way they can look into it. It's better to be preemptive. Diagnostic laparoscopy should be performed for individuals who are actually undergoing treatment. So if you've done your CT scan, you've diagnosed your gastric cancer, and you know that these patients are actually going to go ahead and get chemotherapy, you want to do your diagnostic laparoscopy beforehand, just to make sure that there is no evidence of metastatic disease that you had not seen on the scan, that was not picked up. Because if the patient has metastatic disease, they shouldn't necessarily be getting surgery. Perioperative chemotherapy, generally FLOT, is given for individuals with bigger tumors with nodal disease. And we're still awaiting randomized controlled trials for what was known as TNT, so total neoadjuvant therapy. When we look at the rectal cancer staging or the rectal cancer world, rectal cancer has gone away from surgery first, from chemotherapy, then surgery, then more chemo, to now giving it all up front. So individuals with big rectal cancers, with big lymph nodes, they tend to get chemo and radiation first, full chemotherapy, full on radiation. And then generally after that, if need be, then they'll go ahead and get surgery. So this is what potentially needs to happen with stomach cancer, meaning that individuals should get, especially if they're going to undergo a total gastrectomy, they should potentially, in my view, get full-on chemotherapy first, and then once that's done, then go ahead and get their total gastrectomy. Because even though they give the sandwich therapy, so chemo, surgery, chemo, some individuals, like I said before, never get to that chemo at the end. Because again, it may not be well tolerated. You've had this major operation, and now you want to go ahead and give me another 4 rounds of chemotherapy that I barely survived the first 4 rounds. So some people just neglect to or tend to neglect taking that. Right. So if you can find a way to give it all up front, then you negate that issue of having to give it at the back end. But again, there are no data out there supporting this as yet, but I'm hoping that this will be something coming down the pipeline. And I think that is it. Thank you all for this opportunity. And if you guys have any questions, I'm happy to answer.
Thank you, Dr. Major. As you said, if anyone has questions, feel free to open your mic and ask them. Otherwise, if you put them in the group chat, then we will read them out for you. I see some comments in the chat now. Great information, Dr. Major. Continue to help all you can. And blessings to the Cancer Society for all that you do. It is needed and much appreciated. So thank you very much for those comments, Yolanda Curry. Anyone else has any other questions for Dr. Major?
Can you
Samsung
hear
has their
me?
hand up. Yes, we can now.
Okay. Hey, hi everybody. Thank you, Dr. Major. Listen, my question, Dr. Major, is what kind of questions? I think oftentimes people are intimidated when they get to the doctor, or they tend to forget the questions that they need to be asking. I'm the type of person, one of my best friends always was like, please stay off of Dr. Google. Because I'm listening to you talk, and I'm like, oh, my stomach is bothering me. What's happening? But, what should we when we go to the doctor, what kind of questions do we need to be asking? And, because I just know that so many times we get there and then it's like, oh, well, I didn't know what to say, or I'm embarrassed to say, or help us out there. How should we be approaching you, our doctor?
Well, what I would say to that first is I think you should try and find a doctor that you're comfortable with. So you don't necessarily be anxious every time you go and see this person. So if you find that every time you go and see this person that you're anxious, maybe that's not the doctor for you, right? There are a lot of GPs out there, and a lot of them are really down to earth people that you can sit down and have a conversation with, right? So that'd be my first advice to you. The second thing I always tell people is that if you're thinking of things, you write it down or put it in your phone. So when you get there, you kind of have your list of questions that you want to ask.
That's what I try to do.
I smile a lot of times when I've had the full on conversation with patients, and they'll be like, hold on, let me check my list. I'd be like, wow, that's amazing. I'm happy you did that, because again, when you're right, when you're in there and you're talking to the doctor, your mind is going a mile a minute, so you're kind of all over the place, and he's telling you things you're not necessarily listening. But if it's for consultation, let's say you suspect there's gastric cancer, you should always carry somebody with you as well. So carry a friend, carry a relative, somebody to kind of be there to support with respect to whatever the diagnosis may be.
Yeah.
But now to your question about what should you be asking. So when you go to see the doctor now, things that you kind of worry about is whether or not you're having indigestion. So indigestion is like a big one for gastric cancer. So you're eating spicy foods and you're getting all this heartburn, which isn't normal because you should be able to eat it, right? Or if you're somebody that's taking antacids regularly because you're getting all this heartburn. If you're somebody that, sometimes when you eat food, it feels like it's not going down, or it feels like it's not digesting, or if you're somebody that just feels nauseous all the time, or if you're getting bloaty and gassy, these are all things that, hey, it may not be cancer, but there may be something going on with your stomach. There may be an infection in the stomach, right? Because, like I said before, this is the number one cause for gastric cancer, this bacterial infection. And if you could get that treated, then you will drop your risk of developing gastric cancer drastically. Right?
And so much of that goes back to just early detection, not ignoring the signs.
No. So again, you don't want to sit at home for 3-6 months with symptoms and just, hoping that it'll go away and just drinking tea every day. Right? The earlier you get it looked at, the better it is. I know a lot of people are afraid of the diagnosis. That's the other thing, because boy, you don't want to walk into the doctor's office and he say, boy, you got stage 4 gastric cancer.
Listen, I'd rather hear stage 1 than stage 4. I can tell you that.
If you've been feeling something, please don't hesitate.
Thank you.
All right.
There are a number of questions, comments in the chat, so I'll start with them. Ann Archer is asking, what if you choose to not have surgery after chemotherapy? What is the survival rate?
All right. So again, surgery and chemotherapy for stomach cancer kind of go hand in hand, right? The gold standard for treatment of stomach cancer or gastric cancer is surgery. You have to kind of remove it, right? So I would say if you go ahead and you just do surgery with no removal of the stomach, then the chances of survival are lessened, right? Unless you're somebody that's had a great response to chemotherapy, meaning that you had a big tumor and you had big nodes and they're giving you the chemotherapy and it all disappeared. right? Which doesn't happen that often. Then you may be someone that can be placed in, a clinical trial. Somebody that, hey, we gave this chemotherapy to, and it eradicated the entire thing. We put a camera down. We didn't see any evidence of tumor. And this may be someone that we could watch. But at this point in time, there's really no data out there to support that. So the majority of patients, once they start on that arm, they get chemotherapy. It's usually recommended that they get surgery after, then chemotherapy again. Because we know that these patients with gastric cancer, especially when they become a bit more advanced, they don't do well. 5-year survival is usually less than 15% for advanced stomach cancer. So it's not good.
Okay, C. Johnson is asking, is there a particular reason that countries like Japan have higher rates of stomach cancer?
I suspect it's because of one, the diet, and then maybe the hereditary nature of it, right? It's, I guess, a good thing for us that we don't get it that often, but not so good for them, right? And this is why they tend to have such high screening, and they tend to have such high early gastric cancer, because they look for it, because they know that their population is at risk. That's an at-risk population.
Okay, Dr. Shea says, great talk, Dr. Major. Say a bit more on diet and food preparation to be aware of that contributes to stomach cancer, sorry.
So again, yeah, great question, Dr. Shea. So when we look at foods that can increase your risk for developing gastric cancer, so things such as a lot of grilled foods, right? So that particles from the charcoal and stuff that are getting on your food, that can increase your risk for developing gastric cancer. And I use the word a lot. I didn't necessarily say don't eat grilled foods, because because
We
people
love that grill.
I really love that grill, and I love grill as well. But again, anything with moderation, and then things such as processed food. So the processed meats off of the deli meats, these also increase your risk for developing gastric cancer. Salted meats, these things can also increase your risk for developing gastric cancer. So you want to kind of minimize those things, and not necessarily have them as a staple in your diet daily. And definitely the obesity and sedentary lifestyle. So if you're leading a healthier lifestyle, if you're out there exercising, you're running, you're trying to stay fit, these things you're probably not going to want to lean towards, because they're not going to coincide with your goal. So you'll probably be eating more fruits and vegetables, and less of these processed products.
Okay. And last in the chat, Chico Colley, thank you, Dr. Major. We know that time is of the essence. For the typical patient you get, what is the length of time between tissue diagnosis and completion of the second dose of therapy? Just need an estimate. What is the international standard? And if it varies between patients, what are the factors that lead to the variance? How can we as a society improve? And sorry for the multiple questions.
Yeah, so like you rightly say, Dr. Coy, time is of the essence with pretty much all cancers, and gastric cancer in particular. The timing from diagnosis to treatment can vary based off the facility at which you're I guess attached to. So if you're at a private facility, you can get things done rather quickly. Again, because now either you have insurance or you're paying for it. So these things can be done at an expedited manner. So you can get your diagnosis, I suspect, within, maybe 2-3 weeks. And you can move on to getting from tissue diagnosis to chemotherapy anywhere from, 4 to 6 weeks. So you'd have all your staging and everything of that. And when it comes to the public side of things, now this is where some delays tend to happen, right? Because it's a delay to get in to see the specialist to get your endoscopy. Once you've gotten your endoscopy and you've gotten your biopsy, the pathology kind of takes time as well. And then once you've gotten your pathology, then now you have to see the specialist or the surgical oncologist. And again, this may be a delay to get into their clinic. And then After that, now we have to send you on to see the medical oncologist, put the port in. So generally in the public sector, it tends to take quite a bit longer, maybe looking at maybe 3-4 months, and that's kind of being favorable, right? Between diagnosis and actually getting some form of treatment. And that's not necessarily standard, because ideally you want within that first, 6-8 weeks maximum of getting a tissue diagnosis to getting your first form of treatment. Because like you said, these things tend to be pretty aggressive and tend to be rapid growing. So you need to get on it as quickly as possible. So what some people end up doing is, if they have some form of financial means, they would try and do some things privately that they could afford. And then once they've gone so far with that, then they convert over to the public system. So once they've pretty much gotten the diagnosis with the endoscopy, and they may have gotten some staging imaging, and then they can come over to the public side and see the medical oncologist and the surgical oncologist to try and get their treatment started. But generally, once they've gotten started, it tends to kind of move rather smoothly, unless they have issues with respect to, again, you have to make payments for chemotherapy, and then you also, once you don't have any of those reactions, then you should be okay.
Okay, that looks like it for the questions in the chat. I don't know if anyone else has any other.
I had a question.
Okay, go ahead.
Dr. Major, excellent talk, very informative, as folks in the chat have said. But I've been concerned for a while about exposure to the water table here in the Bahamas. And particularly like here in Nassau, 21/7, basically we got one water aquifer out there. And we tend to throw everything away to the dump, all kind of chemicals going in the water. Do you have any concerns? Is there any evidence to show that chemicals in drinking water can be related to stomach cancer?
Now, I can't say I have any evidence to kind of show that there is some relation to that. But I mean, just listening to you talk, and it sounds like there could be something there. But again, we don't necessarily, I'm not aware of any data in which we've done studies on the drinking water and kind of related those to individuals who develop stomach cancer or any form of cancer in that particular manner. But again, if there are chemicals in the drinking water, then yeah, that's a major problem, and that's a governmental issue that should be looked at and potentially corrected.
Thank you.
Yeah.
Any other questions? Anyone? Comments? No? Okay. Well, then I would like then to thank you, Dr. Major, for that presentation. Very informative, as everybody has said in the chat. Lots of food for thought there. I know we always talk about the gas thing, and Bahamians seem to be so popular with that. Oh, I have gas, and we kind of have gas for months on end. And so, yeah, I think that's a very something really to kind of address as a society, that we have to take more charge of our circumstances and don't just kind of brush things under the rug or hope that things will go away, and also stop all this self-diagnosing. So, because like you say, the earlier detection, you stand a far greater chance of survival. So, great advice there, and I hope that everybody on the chat takes that advice away, if nothing else. So thank you once again for your presentation. Thank you for submitting yourself to join the board and help us in this work that we're doing. And we just can't thank you enough for that. And if there is nothing else, anyone thought of anything they're celebrating? Anyone who joined late that are celebrating anything they'd like to share with us? Feel free to let us know now
Good
before we all
evening.
sign off. Good evening. Go ahead.
Good evening. Okay. Good evening, everyone. My name is Camille. Okay, Dr. Major, I heard it. Your topic. You're talking about stomach. Okay. Question to throw about to ask you about is about breast cancer. Um, i- if if you have breast cancer and each time you visit and chemo treatment and each time you visit the doctor, the oncologist to do your treatment. Is it possible for they to give you an update on all the treatments been in your system?
I suspect you're talking at PMH Oncology, or this is
Yeah, yes, yes,
PMH
sir.
Oncology. So
Yes, sir.
so again, that's more on the medical oncology side of things. So I tend to just deal with the surgical side of things. I don't necessarily deal with the chemotherapy. But what
Okay.
I would say is if you are somebody that or you or somebody that you know has been diagnosed with breast cancer and they're undergoing treatment, chemotherapy, and this is if this is before they had surgery on the breast. So sometimes we like in the gastric cancer cases when you have a pretty big tumor, it's what we call locally advanced, so you have lymph node involvement. We send patients for chemotherapy first, and if this is the setting, then one of the things you as the patient could do, you could kind of just watch the tumor, because generally what's supposed to happen is if you're getting chemotherapy, that tumor should be shrinking and then potentially disappearing. But if you know that
Okay.
it's kind of growing or not doing anything, then this is where you kind of need to raise the alarm and try and see if you can get in to see the medical oncologist. Because I know
Okay.
that they tend to have, it's only a handful of them and they have a lot, very large volume of patients. So it's kind of a challenge to see everybody all the time. So I don't want to necessarily make excuses for the medical oncologist. But again, sometimes it's a challenge in the public system, and then there's certain things that you as the patient may have to do to try and circumnavigate those challenges. So you'll have to really be aware of this tumor and kind of look at it after your treatments, and just make sure you seeing a response. Because if you're not and you feel like it's getting bigger, then yeah, that's the time to raise the alarm.
Yeah. Yes, it is. Yes, it is shrinking, and each visit is like this is the second visit, and they told me that my blood count is low and my white blood cell is low, and no one, when they told me exactly that my blood count is low, it's like no one explained anything else to me. They just tell me that put it off and tell me that I must come back and then do my blood test over. Then I can restart my chemo. So that's why I was asking you, is it possible for each time you do the chemo, if they should give you an update? Yes, the tumor is shrinking, but when you do the blood test, they told you that your white blood cell is low or your blood count is low, build it up and then come back. Yeah, that's it. So
Yeah,
that's my question to ask you if they should like give you a brief run through you, talk to you about the whole thing.
I mean, I think that there is more of a manpower issue, right? We just need, well, not necessarily more doctors per se, but you probably could have, if you have things like nurse practitioners or people that can kind of interpret these things for you and give you a better rundown of what's going on. But white blood cell and your red blood cells or your hemoglobin, they can go low after chemotherapy because chemotherapy basically destroying good and bad cells, right?
Mm-hmm.
And so sometimes the white cells and the red cells, they kind of get destroyed as well and they suffer. So anytime you see somebody with a low white cell or low hemoglobin, they tend not to give those patients chemotherapy, right? At least at that point in time, they want to give them a bit more time for the blood to build back up, and then they'll kind of repeat it. But to say get somebody for everybody all the time, yeah, that's that's a challenge.
Good night. How y'all doing? My name is Tanya Mallory. I just wanted to answer the ladies' questions that were asking you the questions because of my experience that I'm doing chemo treatment right now as well. When it comes to the chemo to the white blood cells, it's not normally that they won't tell you what to do because, like they say, normally after each chemo, sometimes it's liable that the white blood count cells drops low. But when that happens, what you could do to bring it up is, I think, is eat more protein. And that normally would help to bring up the white blood count cells. But that's just something that happens not by anything, meaning that something negative is happening in the body. But I guess it's just due to the treatment of the chemo that it causes the white blood cells to drop low. So what you could do to try your best to prevent that is eat a lot of protein, lean meat, and not instead of red meat. So that's just my input from my experience of getting the chemo treatment. So I just thought that I should share that with you.
Thank you. And Dr. Major,
you.
one more question in the chat before we close off. Yolanda Edwards is asking, April is Stomach Cancer Awareness Month. Do you know of any place that offers free screening for stomach cancer during this month?
So again, like we spoke in the presentation, we don't necessarily screen for stomach cancer because it's not common like colon cancer or prostate cancer or breast cancer. Those are really common cancers. So those are the individuals we kind of screen for. When I showed the data for the Bahamas, basically from our cancer registry that we've captured, it's usually like around maybe anywhere between 10 to 12 people, maybe 15 people a year that are diagnosed with stomach cancer. And you look at the population, it's about 400 plus thousand people. So if you imagine scoping 400 plus thousand people just to find 10 people, it's not necessarily a good investment for your or a good bang for your buck. But what I would say is if you do have symptoms such as heartburn, indigestion, difficulty allowing food to go down. So when you swallow food, feel like it gets stuck, you're feeling nauseous, you're feeling bloaty, gassy, you have an unexplained weight loss, then you'd likely want to go and see your private physician or your medical physician or your NHI physician and let them know this so they could kind of start looking into it and trying to figure out, what it is and why you're experiencing this. But again, there is no screening for gastric cancer. We only have a look in the stomach once we suspect that there's something going on.
Okay, so if there are no other questions, or are there any more questions, comments? If not, then once again, Dr. Major, thank you so much for your presentation. And thank you to each and every one of you that have joined us tonight. Appreciate you being here with us. And I see Erin has put, I think maybe a flyer for the ball in the chat group if you want to have a look at that. Otherwise, I guess it'll be on the website. So thank you all for joining and wish you all a good month, and we'll see you all next month. Take care and stay safe, everyone.
Thank you. Have a good night.